Hi everyone, in this 10-minute video we are going to review the recently published updated NICE guidelines for the management of type 2 diabetes in adults. Now this has been hotly anticipated because it's been about 7 years actually since the previous updated guidance was provided by NICE, and a lot has happened during that time. Over those 7 years, obviously we've seen this paradigm shift, haven't we, from that glucose-centric management of type 2 diabetes to a much broader cardiorenal metabolic approach to managing diabetes. So what has driven that? Well, a lot of it has actually been from the SGLT2 inhibitors and the GLP-1 receptor agonists. We now have a wealth of scientific data backed up by license changes as well that really shines a spotlight on those two classes of agents for not only their glucose lowering capabilities, but actually independent of that, their cardiovascular and kidney protective effects as well. So we've seen that actually over the last 7 years being reflected in several updates of the ADA EASD consensus statement. And to be fair, a lot of our colleagues have been referring to those guidelines. So here we are now in early 2022, and we have a new updated NICE guideline. So Kevin, is it a case of nice to see you nice?
So this is a guideline I had very mixed feelings about, and I know we share a similar sentiment. But in terms of SGLT2 inhibitors, I was delighted. SGLT2 inhibitors have been positioned on point by NICE and really are placed very much the vanguard of all oral type 2 diabetes therapies. Consistent, of course, as you said, with their clinical benefits and the expansive evidence base now. And NICE themselves actually state that SGLT2 inhibitors are now recommended in a much wider population than the technology appraisals that were published before February 2022 when the NICE guideline was updated. So I know this has been our standard clinical practice for the four of us for some while now, but hopefully this will drive earlier usage throughout primary care of SGLT2 inhibitors, particularly those perhaps less familiar with the class. So really delighted to see that prominent positioning of SGLT2 inhibitors. But Amri, what really caught my eye though was NICE also recommended to offer metformin and then, when tolerated, SGLT2 inhibitors in all individuals at high risk of cardiovascular disease with a Q risk 2 score of greater or equal to 10%. Quite an interesting and potentially controversial recommendation, because we're not going to have many people living with type 2 diabetes, are we, without with a Q risk 2 less than 10%. So what were your thoughts on that?
Yeah, I know. Interesting, isn't it? I think it's a really positive step, personally. I think we're aware of the cardiovascular and renal risk that patients living with type 2 diabetes have, not only in terms of Q risk of their 10-year risk, but actually lifetime risk as well. And it's important to remember that. And the early introduction of using SGLT2 inhibitors in that way, well, it will make SGLT2 inhibitors almost the norm in primary care, on par with the way in which we use statin therapy in primary care as well. And to me, that can only be a good thing for our patients. Now, I appreciate that there may be more patients, obviously, therefore being prescribed SGLT2 inhibitors, thinking about patients and their pill burden. But again, if we look at it in a positive light, maybe this is a chance to think about fixed dose combinations early on in patient management of type 2 diabetes and actually effectively reducing pill burden through those measures. So for me, yes, it's an interesting take. It's a positive step, but I think overall it's a benefit to our patients. So SGLT2 inhibitors, as you said, Kevin, front and center with this NICE guidance. Where do GLP-1 receptor agonists sit, Amma?
That's the big question, wasn't it? When the draft came out, we were also kind of SGLT2s, and we thought, where would GLP-1s sit? They focus a lot on this cardiovascular risk and benefit. Would GLP-1s, which have that benefit, also be as high up? But really, from the guidelines that came out, the GLP-1s really haven't changed in their positioning, so they still remain down the line in the treatment. So if treatment with metformin and two other oral agents are not effective, then you would consider triple therapy. Then you would consider GLP-1 agonists. Sorry, and it's still the same restrictions. BMI over 35 and have obesity-related comorbidities or conditions. Or if BMI is less than 35, then we may not want insulin therapy or weight loss, we benefit from other reasons, so obesity-related comorbidities. Nothing mentioned about cardiovascular risk or cardiovascular, benefit in this setting, which is frustrating, I guess, for a lot of us, and myself in a way included, because we see it highlighted so strongly in these guidelines and in all the previous guidelines, AD, ASD, ESC, everything there. Yet in our NICE guidelines, and the time it's taken and the data we've had, it does make it a bit frustrating that they aren't as featured as prominently. And I do question that. I mean, from a practical point of view, would I change the way I prescribe things? Probably not. But it would be nice to have that focus on that, especially when they mention that. Now, the main question I have is why? So, Patrick, why? Why have they placed it like this?
Yeah, I mean, this is the thing which gets me a bit angry and cross, because I don't like injustice, and I think there's been an injustice done here, because what they've done is NICE likes grouping these things together. So it's grouped together SGLT2 inhibitors, although interestingly it did talk about prescribing drugs with clinical evidence or of proven effect. But with GLP-1s, it sort of lumped them all together and said they weren't cost effective. And I think that's wrong, actually. And actually, if you look at the evidence which they produced themselves in their own modelling, you can see that it's quite heterogeneous. And we've got to bear in mind the original scope of the NICE guidance was to look at not just cardiovascular outcomes, but look at glucose and weight reduction. But they didn't, because they had to narrow the scope, because they're running out of health economists, I get the impression. Remember, we've just been dealing with COVID, and NICE have been doing quite a few other things. But so they've just narrowed on this cardiovascular outcomes, which means there's actually been no look at glucose or weight actually since not just 2015, actually 2011 was the last time they looked at this. So that means drugs like gelaglutide, Trulicity, or Ozempic, injectable, well, Ozempic or Rybelsus, different forms of semaglutide, haven't really had a full view of their effect. But if we just look at the cardiovascular outcomes, so it's a bit complicated, because I'm going to briefly mention ICERs. So NICE, remember, is about cost effective, so we can compare treatments not just within diabetes, but across the whole range of care. And they use the cost effectiveness of about 30,000. So if it's below 30,000, it's a thumbs up from NICE normally. And SGLT2 inhibitors are all below 30,000. Or just pretty much all below 30,000. There was one actually just above it. Whereas if you actually look at Ozempic in once weekly semaglutide, it was about 24,000, similar actually to empagliflozin. So why did they not include that? Well, as I said, NICE like lumping it all together. So I compare that a little bit with dancing and men. So some people would say that women are better than dancers than men, and that's possibly true. I don't know, but that's a bit like putting me in the same category as John Travolta. Okay, so I tell you what, I'm not as good a dancer as him. So if any of you see me dancing, even when I've had a few beers, so that's a real issue with this. And then they did look at this in great detail, and they went down the route of looking at a sensitivity analysis. So they looked at various different little outcomes, not just at the composite outcome of a clinical trial in SUSTAIN 6, which would be non-cardiovascular death. Cardiovascular death rather, or non-fatal stroke or non-fatal MI. They went down the individual components, and that's difficult really with a small study. So it doesn't make much sense to me. It was never originally powered for that. So I think there's been a great disservice to at least one, if not more, of the GLP-1 receptor agonists. So that's, yeah. So my view is it's been an opportunity missed, really, with that. And I think, will it change my practice? It won't. But this is really important stuff, because this is NICE. So if you look at system level in England, like an integrated care system, it's going to be difficult to ignore this. Fortunately, NICE are going to be looking at the broader benefits of in terms of glucose and weight, which is surely really important when we're managing people living with type 2 diabetes, and that's starting soon in April, but it'll take a couple of years before we get that. So it's somewhat frustrating. That's my view. So I think this has been a bit of a curate's egg. I'm very pleased with what they've done with SGLT2 inhibitors, but I think they could have done better when it comes to GLP-1 receptor agonists, because if we're prescribing SGLT2 inhibitors, as you say, to the masses, there will be some people who just don't tolerate it. And if they've got established cardiovascular disease, if you follow nice guidance, you'd be prescribing sulfonylureas or DPP-4 inhibitors, which we know do not reduce cardiovascular events, as opposed to using a treatment which does, which doesn't make any sense to me. So they should have done better. What's your view, Kevin, in terms of the overall view of the study, of NICE?
I really agree with you. I think NICE have missed a trick here. Delighted with how they've placed SGLT2s, as I said, and really, this guidelines really making us challenge ourselves. Is there a reason why I shouldn't start my patient with type 2 diabetes on an SGLT2 inhibitor? And I think that's a good question to pose. But as you said, missed a trick with the GLP-1. I think they could have simplified that treatment regimen. Metformin, early initiation of SGLT2, and then GLP-1. But missed opportunity, as you said. What about you, Emma? What was your take home, or how's it going to change your practice?
I mean, very similar to you lots. SGLT2s, yes, that's what we're doing. I like the fact that they say, regardless, we're not on metformin, so dual initiation. What I was doing before. Quick starts, one metformin, and then SGLT2 in the next month or so. So it allows for that, which is great, as with the PCDE guidelines that you mentioned. What I wonder is that the bit about the GLP-1s, where it goes BMI less than 35 and obesity-related comorbidities, could we factor in cardio disease there, or weight and HbA1c there, and link it up? I don't know, but frustrated by that a little bit, but I'm still going to do that and hopefully still do the same things. But what about you, Amrit?
Thanks, Summer. Yeah, I think from my perspective, I think there have been some positive strides, and I think it's particularly in areas of the country perhaps where there's been a pushback of using SGLT2 inhibitors from medicines management teams. I think this NICE guidance really helps support clinicians in those areas. We talked about some of the shortfalls perhaps of this guidance, and there's hope that obviously as we move forward that those can be reviewed. But I think all in all, a step forward at the very least, and something now that we can now say as clinicians, as part of the UK community of clinicians involved in diabetes care, that we now have an updated NICE guideline after all these years. So thanks guys for your thoughts and your comments. We hope that you all enjoyed watching this video at home. If you're interested to hear more discussion and debate on this, please do follow us on our Twitter account and look out on YouTube for more videos to follow. But for now, that's all from us. Take care and see you soon. Bye, everyone.